Our first talk is titled Need of Assisted and Active Rehabilitation Systems for Stroke Survivors, to be delivered by Prabhav Mehra, who is a doctoral student at Trinity College, Dublin. Before that, I would like to give a brief uh, bio of Prabhav. Prabhav Mehra is a second-year doctoral student at Trinity College, Dublin, former research assistant at Chinese University of Hong Kong and BITS Pilani Goa campus alumni. He specializes in the field of neuromuscular biomedical engineering, which is an interdisciplinary study which aims to combine neuroscience and engineering to create diagnostic, prognostic, and rehabilitative methodologies for people suffering from neurological disease. During his 3-year-long stint as a research assistant at CUHK, he and team designed a neuromuscular stimulation-assisted lower limb rehabilitation system for stroke and spinal cord impairment survivors, which resulted in long-lasting neuroplasticity for enhanced lower limb coordination and movement. The system was controlled using biosignals like electromyography and electrocardiography, and a predictive algorithm was modeled and implemented to predict the fatigue fracture point of the muscle before reaching the point of failure. He has published multiple research papers in well-respected journals and conferences. I welcome you, Prabhav. Over to you now.
Yeah, thank you, Ananta. So, yeah, I'll be sharing my screen. 1 second. Yeah, hopefully you are able to see the presentation now.
Yes, it's visible.
All right. Yeah, thank you. Hello, everyone. I'm Prabhav Mehra, a second-year PhD student at Trinity College, Dublin, former research assistant at CUHK and a BITS alumni. I would like to thank IEEE-IISc chapter for inviting me to speak on the topic Need of Assisted and Active Rehabilitation System for Stroke Survivors. So before starting, I would like to acknowledge my supervisors. So currently I'm working under the guidance of Dr. Bahman, who is my doctoral supervisor, and we are led by Prof. Hardiman, who is the head of academic unit of neurology. Before this, I was working under Prof. Raymond Tong, who is the chairman of Department of Biomedical Engineering at CUHK. And under him, we did motor rehabilitation for stroke survivors, which I'll be talking about in this talk. Okay, sorry. 1 second, let me just. All right, yeah. So what is stroke? Stroke is a serious cerebrovascular condition which arises due to the lack of blood supply to a part of a brain. There are majorly two types of stroke, ischemic and hemorrhagic. These definitions are quite self-explanatory. That is that an ischemic stroke happens when blood flow through the artery that supplies blood to the brain becomes blocked. Blood clot is the most often cause for such strokes, and this is the most common stroke that we have encountered and are prevalent in this society. While hemorrhagic stroke happens when an artery in the brain leaks or ruptures, high blood pressure and balloon-like bulges in artery are quite a common reason for it. These are not as common, but we still find a lot of subjects who have gone through this kind of stroke. Yeah. So stroke is one of the leading cause of death in the world. In 2013, there were almost 25 million stroke survivors and around 10 million new stroke cases reported annually. More than 11 million stroke cases were reported in China every year, and all these number of cases are expected to increase because the aging population across the world. And so, if you'll see here, yeah, if you'll see here, so these are the lesions where stroke actually took place, where there was lack of oxygen supply, and these these are the inactive regions which causes motor impairments and cognitive impairments that affect the basic life of stroke survivors on a multidimensional case. Around 30% of stroke patients develop dementia within first year of stroke, and it also affect the cognitive domains like attention, memory, language, orientation. All these functional capabilities are the one that we take for granted, but in case of stroke survivors, it's really a hard thing to come by. So today we'll be mostly focusing on the motor impairment. That is that around 80% of the stroke survivors develop motor impairments contralateral to the lesion hemisphere. That is, that if you suffered a stroke on the right side of the brain, your left limbs will be the most affected part. And these impairment affects functional mobility, independence, and motor coordination. um, so all these muscles exhibit high level of spasticity, loss of control, poor voluntary muscle fiber recruitment, and firing capacity, which is an essential for any movement that any bodily movement. So making effective rehabilitation system is a dire need for them. So active rehabilitation systems, the active part comes from biosignals. So biosignals are generated due to the body functional capabilities, which results in biological activities that produces electrical signals, which we can record non-invasively. So these biological activities are a result of propagating action potentials. So this is a very generic action potential where the resting potential is quite low, like it's in the depolarized state, then depolarization happens and repolarization, and then the resting state. So this is one action potential, and cascades of these action potential leads to a signaling system in a body. So these controlled depolarization and repolarization are a result of opening and closing mechanism of specific ion channels. Like in this case, it is controlled by sodium and potassium channels. Uh, in other parts of the body, there are multiple other channels which might also result in same kind of action potentials. So non-invasive techniques for recording these electrical signals. One of them is EEG, which is generally used for recording brain activity through the scalp. Um, so here, high density, or like between anywhere between 16 to 256 channel cap is used to record those many channels. And then when you see there are multiple well-defined bands that are delta, theta, alpha, beta, and gamma bands, in which we analyze them even further to look into uh, different use cases. And then there are imaging techniques, which are PET, MRI, CET. These are the ones which are based upon functional uh, capability and not directly recording the electrical signals, but rather the functional capabilities of them. And then this is the part that we will be focusing mostly on. It is the EMG signal, which is a technique that is used for recording electrical activity produced by skeletal muscles. And we record these using electrodes into interpretable values. This is a very general waveform of EMG signal, what it looks like. these are the independent muscle unit action potentials. So cascades of them combine together, and then they form a signal like this when you are looking non-invasively. While ECG is a technique that is used for recording electrical signals produced by heart, and ECG is one of the most common used diagnostic methods that we come across in our day-to-day life. So muscle activation physiology. So when muscle activity activates, what are its physiological components that lead to the waveform that we see? So first of all is motor recruitment. That is how many muscle fibers are recruited at particular point of time. So there are different types of fibers, type 1, type 2 fibers, that depending upon the activity, they recruit in different amounts. Then the muscle conduction velocity, which is the time taken for the electrical signal to travel from one point to another point. That is the point of initiation to the end of the muscle fiber for the proper twitch and the contraction. So, so with muscle fatigue, we see that there is a slowdown of muscle fiber conduction and all these things. And then the firing rate. It is the how firing rate is the signals at what rate brain is trying to fire the muscle units. Um, so so we generally see impairments in all of these three categories for stroke survivors. That is, their recruitment decreases, their conduction velocity changes, and the firing rate is also hampered. So now the assisted part is the neuromodulation techniques. That is, we provide external stimulation to brain or to muscles to change their excitatory capability. So different techniques, you can use it to either increase the excitation or to inhibit a particular part of a pathway, the neuromuscular pathway. So in the case of TMS, we use magnetic stimulation to stimulate a particular part of the brain. These magnetic pulses are of high intensity, and they are much more focused than the other other techniques. TMS is one of the most used techniques for depression, while for TDCS, it is transcranial direct current stimulation. So we non-invasively give direct currents to stimulate specific part of the brain. These are low intensity current which is passed through two electrodes over the head, and it modulates the neural activity. While in case of TACS, which is transcranial alternating current stimulation, it's very similar to TDCS, but instead of direct current, we give alternating current. And this is the stimulation that we have used in our study, which is neuromuscular electrical stimulation. So in this case, instead of giving direct stimulation to the brain, we rather provide stimulation to the muscle so that the ascending pathway is modulated. That is, pathway from muscle towards the brain rather than brain towards the muscles. So what happens is that short and fast electrical pulses are used to activate the peripheral nerves, and then it changes the neuronal hyperpolarization or depolarization state. This is an example of active rehabilitation system. So it's an exoskeleton hand that is driven by EMG signal. This is a picture from Raymond Tong's lab, in which we made an exoskeleton system, and it was triggered using the EMG signals that were collected across eight different muscles. So you can see currently there are just one muscle which is shown here, then one is on the other side, one at the thumb, and then biceps, triceps. So there are total 8 muscles which is used to trigger the exoskeleton system. So component of active rehabilitation system is based upon human machine interaction. That is, first you need to select rehabilitation movement. These motions, let's say in this case, it's closing and opening of the hand. So if you are just doing that passively, that is, you are either using your other hand to open or close the affected hand. So that is passive one, in which you are not collecting any biosignals, and there is no intent recognition. So what happens that we decide this rehabilitation motion, then we record the biosignals, in this case EMG. Then we give them the instruction, that is, you have to either open or close your hand, and based upon their EMG activity, we recognize their intention. And if that intention is good enough, that is, if they cross the corresponding threshold that we have set based on their earlier experiments, then the corresponding motion will take place, and the feedback will be generated for the subjects or the survivors to look into. And this gives a complete feedback system, which increases their motivation, and uh, also gives them the feel that they are using their actual muscles, the impaired muscles, to open and close the exoskeleton system, which is better than the feedback system that they generally don't get in passive rehabilitation. So now the need of cycling system for lower limb rehabilitation. That is how can we actually have a proper effective rehabilitation system for lower limb. um, Now, lower limb function is an important part of gaining functional independence, primarily for regaining proper gait movement, that is, walking, sitting properly without falling, or even standing up without the need of any support. So generally, lower limb rehabilitation is trickier as compared to upper limb, because unsupported limb rehabilitation systems or procedures like walking or other such activities are very difficult for them to perform, as there is a constant fear of falling. They cannot control their limbs properly, so they might have freezing of gait and uh, other kind of severe possibilities that can injure them. So cycling seems to be a good alternative for regaining lower limb functionality, as it can be performed in a seating position, and the pattern of activation of muscles during cycling is very similar while walking. So this is the pattern of muscle activation, that is, uh, when your pedal is at 12 o'clock, then your hip flexors will be activated first, after that knee flexors, um, then ankle flexors, then other such muscles are activated in the sequence. So during our rehabilitation, we focused on four muscles that are quadricep, hamstring, TA, and GL. Um, so so these are the muscles that are essential for cycling and walking. Uh, Apart from these four muscles, the other remaining muscle is the hip flexor, but you can change the sitting arrangement of the cycle so that minimum hip flexor is used during that cycling position. So this is the cycling setup that we had. So we recorded four EMG signals from the four muscles. Along with that, we recorded the torque, cycling speed, and the heart rate. Then the assisted functionality was attained via functional stimulation, that is NMES, neuromuscular electrical stimulation. These patches, these gray patches, are the ones to provide these kind of stimulations. So, so these are short pulses of high voltage and and current. So it contracts the whole muscle, and then this it is given in a repeated manner, that is at particular frequency, let's say at a 30 hertz or 20 hertz or something like that. That is, in a second it will be contracted 20 times or 30 times depending upon the need. And then these are the EMG sensors which record the EMG signals. This is the reference electrode. So the functional stimulation electrode and the EMG electrodes were put on hamstring, TA, quadricep, GL, for increasing the muscle coordination. Active control of the setup comes based upon that the speed will be automatically adjusted based upon the coherence between the applied force through the muscle activation that we will record using the EMG signals, and the muscle that should be activated based upon the cycling pattern for muscle control. What it means is that if hip flexors are to be if hip flexors are to be activated in this particular cycle, in this particular angles, then if you're not applying, like your muscle is not activated during these angles, then we will not increase the speed, or or even your speed could be decreased because you're not doing the exercise properly. That is, you're not able to control your muscles, and there is no proper muscle coordination. So this will increase the motor control. So real-time signal processing of the EMG signals. So EMG signals were collected at a sampling rate of 2000 hertz, that is 2K sampling hertz. Then they were processed in a batch of 350 samples, that is, a window of 350 samples will be processed in one go. First, basic pre-processing will be undertaken. That will be checks like the collected signal is essentially a EMG signal, and there are no other interference from other electrical sources. After that, like you can see, uh, these red points are the functional stimulation pulses. So these are the external stimulation that happen. So we need to remove these external stimulations and only keep the blue part, that is the desired EMG signal. So after removing these external stimulation pulses, we only get the voluntary EMG signal that will be used for controlling the cycling system and essentially increasing or decreasing the speed or the intensity of the stimulation. So we did that by first differentiating the EMG signal and then finding the instantaneous points of these NMES stimulation pulses. The spike of EMG signals was also removed. That is, that after after uh, after this external stimulation, there is an involuntary M wave that is caused due to the external stimulation, which is first detected, and then we reconstruct EMG signal based upon the previous signals. That is, based upon the history of the muscle, we will try to reconstruct these signals. And once that all this is done, then we will remove the 50 hertz harmonic filtering. So to finally get the desired EMG signals without any external stimulation pulses or any other artifacts. Now, how this will be used to uh, control the cycling system. So what we will do is that we will see how much of EMG signal was in the activation period, let's say hamstring. So how much of hamstring EMG was in the angles that hamstring was supposed to was supposed to contract minus the baseline value, whatever the baseline is, and then the divide by concentric contraction. That is, what if the force was applied in the proper activation period. Let's say he or she applied around a few millivolts of EMG signals, and they were completely out of phase. So this will become zero, and that means that the intended EMG was not achieved. While if it was applied um, right in synchronization with the activation period, then this will turn out to be 1. So it will be a ratio between 0 to 1. Then we'll add it across all the angles and all the EMG and divide by the total angle. So now we will increase the speed if it was 50% of the desired threshold, uh, like desired contraction, but we will decrease the speed if the applied muscle contraction was not even 30% in synchronization with the activation period. So if it was more than 50% of the activation period, then the speed will increase, otherwise it will decrease. If it's between these two, then it will remain the same. And the same will also be applied to the threshold of the NMES pulse. Um, that is the intensity will be increased if you are doing better, but if you are doing worse, then your intensity of stimulation will be decreased. So this will give them additional motivation to cycle properly in the intended manner, and increase their muscle coordination, intermuscle coordination, and individual muscle control. So this is the final system, how it looks like. So we are not discussing about the EEG part of the study. We are only looking at the EMG part of the study right now. So these are the EMG electrodes, like I said, and the stimulation uh, patches. This is the control system where there is a stimulator. There are relays to control the motor properly, and this is the feedback, or essentially the interactive screen that shows you which muscle is currently uh, like in which muscles he's actually applying force and which muscle should be contracted. Then there's also visual representation, that is which muscle should contract at particular point of time, the speed and the torque of the whole system. Then the pedaling system has a torque sensor, has a proper driving motor that drives the system, and in fact also have optical encoder to give us the right angles at particular point of time. So this is the system that was built in house, right from the amplifiers to the whole system. So the signals and the analysis that were taking place. So first of all, we looked into the clinical scores, because these are the real life scores, or the real life clinical activities that are used to assess how good the lower limb rehabilitation is working. So 6-minute walking test, that is they are able to walk 6 minutes without any support, and uh, how much distance did they cover. Then Frugal Meyer assessment of lower extremities. This contains uh, bunch of uh, bunch of clinical assessments that looks into the spasticity and other things. Then Berg balance scale, which is to see their balance while walking. And then there's rhythmic muscle activity, that is the muscle activity changes that are in synchronization with the cyclic pattern. So did their synchronization with the cyclic pattern increase, or did it decrease over time? Intermuscular coherence. So that is how good is their muscle coordinating with each other, is there proper coherence between it. And then muscle balance, that is balance between the unaffected and the affected side. So by the end of your rehabilitation process, your unaffected and the affected side should be as balanced as possible. So if you come to the results, you'll see that most of the clinical scores, they increased after 20 sessions of training. Their balance increased, their 6-minute walking test increased, their balance, like SIS, like balance between affected and unaffected side, also became better, and all of them showed proper clinical significance. Yeah. While for muscle coherence, there was increased muscle coherence in between EMG between different muscle groups, but it was not clinically significant. While the muscle activation was also increased, that means that they were able to apply more force as the training went on, and all of them reported that by the end of the training they had better lower limb control and coordination. So another important part of the study is muscular fatigue. That is, uh, that as soon as your muscle starts to get fatigued, the person showcase inability to perform the task at the maximum output. So continued muscle fatigue can lead to endurance limit. That is, you are not able to perform the task any further, and you have reached your fracture point. And then, so if there is excessive training, then it can lead to unintended negative effects, and can create even more problems than the solution. So due to neuromotor connectivity issues, the stroke subjects are unable to sense their level of fatigue during active rehabilitation. So generally, we do have a physiotherapist or a physician present at the site of training to assess the muscle conditions. So what will be really helpful will be that if we are able to automate and able to measure the muscle fatigue during rehabilitation without the need of any physician or physiotherapist present at the training session. So some of the EMG characteristics which changes as the muscle becomes more fatigued are following. Then there is a decrease in mean or median frequency of the frequency spectrum, EMG frequency spectrum. The frequency spectrum itself compresses over time, and then there is increase in the EMG signal RMS amplitude, because the lower frequency components increases. So low to like high to low frequency component actually increases. Above characteristics are resultant of changes in muscle physiological factors like muscle conduction velocity, firing pattern, and recruitment changes. The physiological characteristics that I showed earlier in the presentation. So this is how a EMG spectrum looks like, and then we try to model it using different probability distribution curves like gamma or Weibull. So the gamma distribution and Weibull distribution showed good curve fitting for the EMG spectrum, and then we can use the properties of these distribution system to look into the reduction of mean frequency or the compression that is taking place. Yeah. So, so changes in frequency characteristics is that before fatigue, it was like it was not compressed. The mean frequency was much higher. Um, Sorry, this is the 97th percentile, I think. Yeah. So the 97th percentile covered, which show that it was not compressed. And then later on, as it uh, as it becomes more and more fatigue, it starts to compress. This what can be seen over the training period. So as the training period increased, the shift was much more drastic. So there was spectrum compression, there was decrease in mean frequency and standard deviation mode frequency, magnitude increases. Yeah. So if you'll see the normalized magnitude of the mode frequency, it is also increasing, which shows that the component that is high to low frequency component is changing. Now, what is the explanation? What is the physiological explanation of these changes? So, first of all, is the MUAP stretching. That is the muscle unit action potential, which we saw earlier. It stretches in time because of the decrease in conduction velocity. The time for it to take to reach from the point of initiation to the end point, that is decreasing. So conduction velocity is also decreasing. MUAP waveform itself is stretching, and and then all this is even enhanced because our tissue acts like low pass filter. So already the lower frequencies were increasing in the characteristics, in the electrical characteristics of the MUAP waveforms. And then when you even low pass it further, so it enhances those characteristics, and we get something like this. Um, so one thing which we try to look is that how are our spectrum features, how could our model spectrum features relate to the non-model spectrum features? That is, when we modeled it using gamma or Weibull distribution. So um, do they also showcase similar trends when we don't model it and use the traditional methods of calculating mean frequency and median frequency? So in the model features, we have scale parameter and the shape parameter. So scale parameter is the one that relates to the compression. That is, if the shape is higher, that means that it will be much more widespread. As soon as the shape parameter starts to decrease, it becomes more and more compressed. So it can be seen that the shape parameter was decreasing, and the scale parameter was decreasing. Then there's a shape parameter. So the shape parameter is very interesting. So like you can see, there were not many changes in the shape parameter. It was more or less a straight line. Uh, so what that means is that the basic characteristics of the frequency spectrum remain the same. That is, there was at least at high load, there were no changes in recruitment, which means that the muscle fibers which were recruited at the start of the training remain recruited throughout the training. There were no new recruitments that can change the shape of the frequency spectrum. and and then when these two parameters were used to calculate the mode frequency, average mode frequency, then it shows very similar trend to median or mean frequencies that we generally use traditionally to calculate stuff. And then the average skewness, which corresponds to how much skewed your your distribution is, it remained the same, which in turn points that the shape was more or less same, and it did not change much over the time. Now, now what are the near future research that we are going to do? So that corresponds to muscle fatigue. So first of all these muscle fatigue research that we did was actually not done during dynamic process like cycling system. So this was rather done in an isometric system, that is, you have to provide an equal amount of force for a particular amount of time. So it is isometric and not dynamic. While most of the rehabilitation uh, movements that we have is a dynamic system. So we would like to implement these muscle fatigue modeling techniques to the dynamic system like cycling that we have. And then we will like to implement it in real time, because all this thing was carried out uh, after after the collection of data. So we had two parts of the study. One was related to the rehabilitation system using the cycling system, and then second was much more exploratory study, which involves with muscle fatigue. That is, how can we incorporate muscle fatigue, how can we know about muscle fatigue so that we can later implement it in the in the cycling system. So the conclusion of the experiment was that EMG-driven NMES cycling system shows improvement in muscle activity of stroke survivors upon clinical examination, and the improvements was found to be that they increased muscle strength. There was much more balanced force production from the muscles, the coordination between the muscles increased, and all of these things are really important for gaining functional independence for stroke survivors. That is, hopefully, if they keep on doing these trainings, they will be able to walk properly, or in case of upper limb rehabilitation like opening and closing of hand, they will be able to grab a pen or a pencil or a glass, and they will not need assistance from family members or a daycare taker. So when it was compared to passive systems, it showed that the that our active rehabilitation system was much better, because the FMALE score was not significantly improved for the passive system, while for the active system, we showed that it was clinically significant, and that too by a really high margin. The so the improvement in clinical scores could be due to EMG driven system as opposed to passive system. EMG driven systems are able to give real bad feedback, which helps the subject to perform the activity with intention or potentially increase the effectiveness of training. So one of the benefits is that the more you are in synchronization with the muscle activation pattern, the more harder the training gets, the speed increases, the stimulation increases. So it is a direct feedback to the brain that they need to keep putting that amount of effort, otherwise the speed will decrease and they will not get the desired result. Results suggest that EMG driven systems are able to improve muscle strength and coordination. Assisted and active rehabilitation system could be implemented in day-to-day rehabilitation process of the stroke survivors for increased motor control and coordination. This can provide holistic development of neuromuscular rehabilitation, thereby providing functional independence of the survivor. Yeah. All right. So these are the references from the lab. So if you want to learn more about the muscle fatigue thing, then you can read this paper. So we even moved one step further. That is, we are able to predict when the endurance point will reach. That is when you will not be able to continue doing the work using supervised learning like SVM algorithm. And and then if someone is interested in the EEG pathways or how EEG was later incorporated in the study, then they can read this paper by Shichun, that is pathway specific modulatory effects of neuromuscular electrical stimulation during pedaling. Um, they show that um, after active rehabilitation system, the corticomuscular coherence, that is coherence between the brain output and the muscle output, it increased. So they were much more in sync after the training as compared to before the training started. And then other papers are the ones that I talked about, which are related to um, the rehabilitation process. All right. Thank you. If you have any questions, then uh, I'll be happy to take it right now.
If anyone have any question, they can unmute themselves or type in the chat.
Yep. Yes. So hopefully everyone is like was able to learn something, that is the need of active rehabilitation system and how you can use biosignals like EMG or EEG. Like right now we are trying to use EEG to even further see how much the neural communication changes, because all this what I talked about earlier was at the peripheral level, that is it was at the muscle level, that there was increased coherence, and I wasn't able to show you the actual EMG signals and how coherence looks like between EMG signals, because we have still not completed our research on it, and there might still be paper coming out, so I cannot share those images with you. But yeah, it was on the peripheral level, and soon we will also look at the EEG level. Well, I have left the lab, but hopefully the research team will look into it and are looking into it.
Sure, thank you. So I was just wanted to ask that you are doing this study on stroke survivors. So can this
Yeah.
type of rehabilitation be done for people who have this kind of impairment, not because of stroke?
Yeah. I think so. Um, it can be translated to any other neurological diseases in which there's a need for rehabilitation, or even in case of sports injuries, um, like you see that if someone goes through a really brutal sports injury and they have extreme impairments, then they do use active rehabilitation systems for um, for this kind of rehabilitation. So this can be translated to any studies in which there is severe impairments.
Thank you. It's really engaging, and what you're doing is really good.
Thank
So
you.
we have something for you. Just a moment. I hope it's visible. So
Yeah,
we have made this flag for you, just a virtual token of thanks for
thank
taking
you.
some time and delivering this talk. Thank you so much.
My pleasure. Thank you. Thank you for having me.
Yeah.
All
So we
right.
have another two talks lined up. If you wish, you can join them as well.
No, okay. Thank you.
Thank you.